call. Feel free to sign into the webinar link so you guys can see the presentation. So I am actually going to go through roll call, and then I am going to give the reins over to Sylvia so she can announce our surprise that we have with the presentations. All right. Is Whitney Arrington on the line?
Yes.
Roger Alston? I know he's in clinic. Christine Ferrero? Swati Ben Patel? Ronnie Gibbs? Angel Jones? Brandy Olive? Okay, I see Brandy's on the webinar. She probably can't hear me, but Brandy is on. Kathy Clark? Kathleen Miller? Dr. Imami? Jackie Thompson? Margaret Ann House? Wendy Crumpler?
Here.
Hey, Wendy.
Hello.
Janice Thigpen? Jennifer Holmes?
Here.
Hey, Jennifer.
Hey.
Carrie Royer? Denise Stiltner?
I'm here.
Hey, Denise.
Hello.
Lisa Keller?
Good afternoon.
Hey there. Carolyn Starnes? Ann Syme or Ann Sim? Michelle Husky?
Here.
Hey, Michelle. Sherry Blevins?
I'm here.
Hey, Sherry. Sonia Triplett? Gail Bowman? Evelyn Brow?
Here.
Hey, Evie. Dr. Betty Ann Mincy? Tina Coffey? Lynn Tomasic? Wendy Jackson? Dr. Paul Ziomek? Okay, and then from our team is Sylvia Coleman on the line.
Yes. Good afternoon, everyone.
Hey, Sylvia. Is Christina Condon on the line?
I'm here. Hi, everyone.
Hey, Christina. Dr. Sarah Jones?
I'm here.
Hey, Sarah. Sarah Lycan? Lori Medham?
Here.
Hey, Lori, and I'm here, Rika Abbott. Is there anyone on the line that I missed?
Hey, Rika. It's Misha and Pam. Dr. Duncan's here.
Oh, hey, Misha and Pam. All right.
Hello.
So can everyone...
Melanie Fox.
Oh, hey, Melanie.
Hey, how are you?
Good. How are you?
Good, thank you.
Can everyone see my computer screen before I turn the reins over to Sylvia?
You can see it.
Okay, good. All right, Sylvia, I'll give the reins over to you.
Hey, thanks, Rika, and thanks, everyone, for carving time out of your very busy schedules this afternoon to join us for our first of 3 webinars in our series on strategies to facilitate return to the important Compass Clinic visit and receiving that all-important ECare plan to help your patients find their way forward to recovery, independence, and health. For those of you who I've already met with for our monthly conference calls to talk about your performance measure reports and your site-specific
with physicians, specialists, nurses, and technicians who provide both the latest treatments
is that we do have what we're calling a stretch goal of at least 70% of your patients returning for their 7 to 14-day clinic visits and receiving their ECare Plan, and thus having all of the resources and support that they need to move forward. We would, in the ideal world, 100% of the patients would come back or close to it, but we know that all of us deal with challenges with patients, and we personally with getting back to all of our important appointments as patients and caregivers following TIAs and strokes, and particularly strokes. So we want to make sure that we are sharing with you some good strategies that have been used from our sites that are hitting this 70% stretch goal already, and sometimes going above that. We do have a post-acute coordinator from each of our waves. We're going to go sort of in reverse order today because of some scheduling. We're going to start with wave 3 and have Whitney Arrington talk with you from Fry Regional Medical Center, followed by Melissa Hanrahan from Mission Hospital. And then we have a recorded, Sarah Day is from Hugh Chatham, is in clinic this afternoon. So we want each of them, our objective is to have each of them share their journey from where they started and where they are now with meeting this stretch goal, including innovative strategies that they have used that might also work at your sites. We will have some discussion between and at the end of these presentations, and we're going to leave you with a tips sheet, a one-pager that summarizes the strategies and helpful hints that you're going to hear about momentarily. And then what we're going to do after we get through today and through next week, all of our wave intervention site calls and webinars, then we're going to summarize in a motivational coaching script for you all to use as you feel will be beneficial, that will be coming to you in the very near future. So without further ado, so that we have plenty of time for these presentations, I'm going to turn over to our first presenter, to Whitney Arrington from Fry. So Whitney, if you would please take it away for us.
Okay. So super glad, let's see, this one, okay, good, I have the control now, perfect. So super excited to talk to you guys today about some things that we have implemented at Fry and with our neurology clinic that's actually not owned by Fry, so that we're partnering with in order to get the patients into their 7 to 14-day appointment, and tell you guys a little bit about some of our successes and also our struggles. So I'll go through this. I tend to talk fast, so if you guys need to stop me and tell me to slow down, feel free. Maybe. Let's see. Rika, oh, there it is. Perfect. Okay. All right. So our initial process, of course, we were not unique in the fact that we worked through trying to find somebody who was going to be consistent enough to be our PAC and our APP. Of course, myself as the PAC, I wear a lot of different hats, as I'm sure most of you guys do within your hospitals. I'm also the stroke coordinator and the administrative director of our stroke unit, so it kind of all tied in together and made the most sense for me to do that. And then our local neurology clinic in town, we have a really good relationship with. They do all of our consults here at the hospital. So we were fortunate enough that our stroke director here at the hospital actually has his own PA who is dedicated to seeing these patients. Of course, with both of us having very busy schedules, we knew immediately that we really needed to carve out some consistent time to make this process work, not only for us, but also work for the patient. So we probably, like most of you guys have found, is a lot easier is to dedicate a slot of time each week to be consistent. That way we don't have to interfere with our other schedules as far as carving out time or running the chance of missing appointments due to our everyday demands. So for us here at Fry, we do every Friday morning. We find that we looked at our stroke population and kind of guesstimated to begin with how many appointments we would need. And so right now we're doing 4 appointments every Friday, which works really well for us. We have not yet had any issues with not getting a patient in within that 7 to 14-day block of time. So really, if that's something that you're challenged with, I would really encourage you guys, if it is possible, try to do that carve out or that dedication of time, because it's worked really well for us, and that way we're not competing with other demands throughout our day to try to fit these patients into a scheduled block of time. Fortunately for us as well, we were kind of able to implement the model and carry it out as it was designed. For myself, I'm able to make the initial contact with the patients here in the hospitals before they leave. About 99% of our patients end up on the stroke unit, and so with that being said, my staff are just able to call me throughout the day to let me know if there's any stroke patients who are maybe newly admitted or who are nearing the end of their workup and are about ready to go home. So at some point during their stay, I can meet with them, give them the folder, and explain the study, and that's really contributed a lot to our success, because what I find is patients, at first, whenever I initially say it's a study, they do have a little bit of apprehension about that. So being able to have that in-person conversation with them, I feel like really makes all the difference in the world. The other thing for us that was initially a challenge was being able to find a way that we could identify all the patients who come through every day that are stroke and or TIA patients. And so for us, we actually use the diagnosis codes that were initially given to us when we went to boot camp, and our wonderful CI team here at the hospital was able to organize a report that comes to my email every day. So every morning when I come in, I have an email waiting on me of every patient here in the hospital, what their location is in the hospital, and what their diagnosis is. So I'm able to track those patients every day. That way we don't miss any patient that may have gone home, even if it's a patient that has left from the ER. I'm able to find that out as well, so that I can get in touch with them. So what works well for us, I've kind of already shared some of the things in the first slide, but for us, it's important that the APP and the TAC both shared the same goals for the study, aligned our processes, and we're able to find some commonalities as far as our scheduling goes, and as far as things that worked well for us. And we kind of debrief every week after we have our clinic appointments to talk about things that maybe we can do better, things that already are working well. And so we're constantly tweaking our process to make it the most efficient, and also for our patients to get the most out of the visit when they come. Like I kind of briefly touched on already, I'm able to execute pretty much every step of the Compass model. I also have trained, at this point, a backup PAC who is our charge nurse on the stroke unit. So when I'm not here, she's able to kind of fill that role for me. And like I said, we do dedicated times for the clinic. So every Friday, starting at 7 a.m. to 12 p.m., I know that I'm at the clinic. And whether or not all those appointment slots get filled up or not, I dedicate that time there and in my downtime. So if a patient doesn't show up, or maybe I only am seeing 2 or 3 patients that week, I use that dedicated time, even if I'm not seeing a patient, to go ahead and do my 30 and 60-day calls. And I find that that works best for me, because that's time that I've carved out that I know is not going to be interrupted by other demands, because I'm actually off-site at the clinic since it's not here at the hospital. As far as getting patients back to the appointment and making sure that they show up when we initially schedule that appointment, we do a series of different things. Of course, making that initial contact with them in the hospital, making sure they have that appointment before they walk out the door. So the neurology clinic here was able to give me a direct line so that I wouldn't, it takes me about 2 minutes to make an appointment for a patient before they leave. So decreasing that time in which we're waiting on appointments helps for us to become more efficient, and also it decreased the risk of a patient leaving the hospital without an appointment. Because what I find is on those patients that maybe are discharged over the weekend and I am calling them for an appointment, you run the risk if they don't pick up the phone, then they're not going to get that appointment made. So we really try to make every effort to make sure they have an appointment before they leave the hospital, and they're aware of that. For the neurology office, they also provide a phone call to the patient 1 to 2 days before their appointment to remind them that they have that appointment. And that kind of coincides with my 2-day phone call as well, in which I'm really reminding them that one of the most important pieces to this is making sure they get to their appointment. And in that phone call, stressing that this is, trying to close the loop of their hospital stay and making sure that we've done everything that we can for them as far as prevention and treatment-wise. It took a little bit of time for us to get down our workflow, but since we've tweaked, and we're about a couple, 3 or 4 months into the study now. We've found a really good process that works well for us. It's going to be different, I'm sure, for everybody, depending on your neurology clinic size and the number of patients that you see. But we've gotten our appointment times down to about 45 minutes. So we're very efficient in our processes and making sure that everything is patient-centered during the appointment time. We find that 1 day a week is enough to serve our patient population and make sure that everybody has a chance to be seen within 7 to 14 days. And usually whenever I see that patient in the hospital, I'm able to kind of gauge and talk to the nurses to see if it's a patient who needs to be seen that week, or if we have any appointments left open, or if they can be bumped out to 14 days. So we really do that based upon the patient condition. And then I already kind of touched on the fact that I get that emailed list every day to ensure that I'm not missing any patients throughout the hospital that may have had an initial diagnosis of TIA or stroke. So achieving enrollment, really I feel the most important piece of this whole puzzle is the proper scripting and presentation of the study itself when you make that initial contact with the patient. Of course, for a majority of my patient population, they're not as familiar with the whole stroke process itself as they are maybe some of the other clinical conditions that they hear about, like heart attack or respiratory issues. So I really try to bring it back to the patient because they're more familiar with those type of clinical diagnosis. I kind of make it to where they understand, okay, if you had a heart attack, you would see a cardiologist. So because you've had a stroke or a TIA, it's just as important that you see a neurologist. And for me, that's kind of like that light bulb moment for them. Sometimes it's taking it to relate it to another diagnosis so they understand the importance of the follow-up visit within 7 to 14 days. Of course, patients, the number one question that I get or that I got asked within the first couple weeks of this study was, how much does it cost? Most of our patients have financial limitations, or they're very aware that a lot of these studies do involve some kind of cost. So I'm very upfront in the fact that I let them know that no matter whether the patient was in the study or not, it would be the expectation that they had a follow-up appointment. So really the study itself is not going to cost them any extra, but only benefit them for our hospital model as far as the recovery process itself. And so that tends to help as far as having that discussion around costs that are associated with the program. I always sit down at the bedside when I'm talking with these patients to achieve them not feeling like they're rushed or that I'm, in a hurry to get in and out, to allow them time to ask questions, because they do have questions about the study, what it entails, and what's expected of them as well. Setting those expectations for the patient to let them know that they're going to be an active and the most important piece of this puzzle, making sure that they are contributing to their recovery just as much as we are. Barriers, still, with the demands of pretty much everybody who's in healthcare now, we're wearing several hats. So making sure that you find that consistent time to complete your follow-up phone calls and scheduling those appointments, for me, has been the biggest challenge. But I feel like, making sure that you carve out that time for me has been the thing that has contributed to our success of getting the patients back in the clinic, making sure that those follow-up phone calls are done within a timely manner for the 2-day phone calls, so that they know what you've promised them in the hospital and when they can expect to be hearing from you is being fulfilled after they have made that initial contact with you. Also letting the patient know that you're going to meet them at the appointment, because a lot of times patients aren't used to that, so they don't expect it. I know a lot of times when I present that to the patients, it makes them feel much more comforted to know that somebody who's seen them in the hospital is also now going to see them in the neurology clinic, because you've already formed a relationship with the patient at that point. Initial barriers for us too were, getting somebody up trained to be the backup PAC. We all want to be here, I'm sure, making sure that our stroke patients are taken care of. But for myself, I don't work weekends routinely or holidays, so making sure that your staff that are routinely taking care of those stroke patients are aware of the study and can at least initially present that to them so that they can expect to hear from you within the near future. And then making sure that you have a way to capture those patients who are discharged from the emergency department. For us, most of our stroke patients are absolutely admitted, at least under OB status, but some of the TIAs that are resolved in the ER, and they have a good plan, they will get discharged from the emergency department. So just making sure that those patients are just as important as the patients who are with you on your OBS unit or your stroke unit, making sure that they get that same opportunity to have the COMPASS model as well. So I think for us, the strengths of the COMPASS at FRI would be our efficiency, the fact that we have a consistent process at this point to make sure that we're seeing all the patients, making sure that the care plan is distributed at that appointment, so that, you know, really the appointment is not closing the loop, but kind of just another step in their journey towards their recovery. So, you know, again, reminding them at the appointment that you'll be contacting them a few more times to make sure that they're doing okay and that you're also a resource for them, that they don't have to wait on you to call them if they have questions. And then also, you know, it's a great opportunity for me to be engaged with our stroke patients on an everyday basis and follow them throughout their whole recovery process, or at least the first 90 or so days. And what I find, you know, is patients, even though you're kind of closing that loop at 90 days, they still continue to call you, and they have that lasting relationship with you, which loops them back into your hospital for the long term as well. And then making sure that we're supporting patient outcomes as for the care model for stroke and pushing that forward. And that's all I have. Does anybody have any questions for me?
Hey, Whitney, this is Christina. That was a fantastic presentation. Can you just discuss a little bit about how did you get your hospital to email you the TIA and stroke patients?
Sure.
Did you get their process? That'd be great.
So for us, we use Cerner here at the hospital. So historically, you guys, if you worked in Cerner, may know that it's not the easiest program to navigate as far as finding your patients every day that are going to be included possibly in this COMPASS model. So we have 2 nurse clinical informaticists here at the hospital who were so gracious to help me. What they actually did is I took the sheet, the eligibility sheet that included all the diagnoses that would fall in the COMPASS model, and we included those in a report. So essentially what it does is they run the report and it queries in the background any patient that has been admitted today or the day before. So like today, when I get today's list, it queries any patient in the hospital within the past 24 hours who's had this diagnosis code. And what that does is it allows me, so say last night there was a patient that came in through the ER at 9 p.m., TIA that was discharged. It allows me to capture that. That way I can make sure I'm making a timely phone call to that patient today to let them know, you know, to kind of start that COMPASS model. So they're not, you know, I'm not finding out a week later, oh man, we had a TIA patient who came through the ER. And so that list being ran every day is done by our clinical team, and so they just shoot that email to me every morning around 8 a.m. So it's literally sitting in my inbox when I come in. And my workflow is that I, you know, before I do anything else throughout the day, I take a look at those patients, see if they've been discharged, if they're still admitted, and start working on the initial contacts for those patients each day.
Great, thank you. It's awesome. Thank you so much, Whitney, and I would like to continue entertaining questions on Whitney's presentation, but I want to make sure we get to the other 2. That was outstanding, Whitney, and we will have some time at the end for additional questions, but I would like to make sure that we get Melissa's and Sarah's presentations in. So again, Whitney, thank you so very much. That was outstanding, and I took lots of notes, and we'll be summarizing this information for you all in yet an additional handout that we will be sharing with you after the webinars. So Whitney, thank you, and I'd like to turn over now to Melissa Hanrahan from Mission Hospital, a Wave 2 hospital that's also achieving this 70% stretch goal. And so Melissa, I believe Rika has been able to turn over the presenter to you.
Yes,
so
I now have control.
Wonderful, you have control. You've got all the control, so you take off. Thank you so much.
Thank you guys for you know, letting us give up some of our information and tell you a little bit about our journey. I will it was very similar to what Whitney has said in many ways, and I see we've utilized some of the same strategies. But startup, always a difficult task is finding your patient list. So we also use Cerner at Mission Hospital, and I have we already had, as a stroke coordinator, had a patient list or a task list that generated to me. So I knew all my stroke patients that were in the hospital.
Stroke. If you have diabetes, it's important to keep close track of your blood glucose.
Excuse us, Melissa. If you can hear me and you have your phone on hold, if you would please take it off and put it on mute.
Daily exercise into your routine and quit smoking today. For more tips, visit diabetes.
Unmute Melissa. And then
okay, so I had a patient list already, so finding my patients that were concurrently in the hospital was pretty good, but we'll talk about a little bit later what we had RIT, nursing informatics, help us with was very similar kind of concepts. Our space, of course, finding where we're going to see these patients and what providers will do the follow-up. We have a neurology outpatient office that is based with Mission Health System, but they were already seeing some of our stroke patients, but it was not common practice for all stroke or TIA patients to go to see the neurologist. It was really based on provider feeling if they felt like they needed extra follow-up or not. So that was kind of a new thought process for our providers of really getting any stroke patient or TIA patient going home to follow up there. And then we had to utilize office space as far as when we were going to have our clinic. It was really when they had the space available. They're a very busy neurology office, and it really came down to when they would have a spot open. So we had begun on Thursdays. We had a whole day Thursdays. We started off kind of slow with just scheduling 2 appointments, and we quickly moved up to 6 appointments every Thursday. Because of space, we've now moved to Fridays. So we see 6 patients on Fridays, and then we're having a little trouble getting the amount of patients we had within that 7 to 14 day period. So we've now had to move another half day so we can see another 3 or 4 patients either on a Thursday, or sometimes we're actually running 2 NPs and 2 PACs at the same time, or at least for half the day on Friday. So some of our learning goals also were training. So we utilized, I myself was the first PAC, and then we've trained another RN that came into the program to be the main PAC, and we had to learn an outpatient EMR system. So that was part of our goals, is learning if we're not utilizing the same EMR system. We had to learn that. Scheduling, initially it was taking longer than 60 minutes. We were scheduling our patients for a 60-minute period, but they were consistently taking more like 75 minutes. We've got that down now to where we are scheduling them for 60 minutes, and we're pretty accurate at seeing patients for 60 minutes now. Follow-up care. So some of those bumps in the road, so to speak, for the follow-up care was as I said, our APP was actually an inpatient nurse practitioner originally. So if we had a patient call with questions or concerns, she was not available 24/7. So we had to come up with a system of who did we call, and if she wasn't on that day, because she was used to working 3 or 4 days a week in the hospital. So on those other days, we had to find somebody else that was available to answer questions that the nurse could not. And then finding that backup is very important, a backup PAC and APP for vacations and sickness and anything else that may come up. So let's see, I have controls, but it's not turning. There we go. So some of the things we've learned, how to get patients to the clinic. We are, like I said, working with IT. We had a list, and we knew the patients that were in the hospital, and we really worked hard to make sure that we see the patients prior to discharge. As Whitney said, that seems to be a critical piece of getting them to actually come to the follow-up appointment. One snag we had was finding our patients that just came to the emergency room. So the list I had was inpatient only. So trying to figure out how do we work on knowing when our patients that come in and only get seen in the ED, not having to wait on them to be, fully coded or anything like that for other current reports that we had. So we had to work with IT on creating an email notification that we actually get daily of any patients for the last 24 hours that were discharged from the ED with those certain stroke diagnoses. And then as far as trying to meet, we have a very, as Whitney said, we all wear multiple hats and are busy with things. So really making sure we saw patients before they discharged was important to us. We asked our IT to actually, we get an email notification now as the doctor or the provider puts in the discharge order. So we might be following the patient and think they might be discharging either today or tomorrow, but now as we're working on other projects in our computer, we actually get an email that'll pop up and say, we have a discharging patient, so that we can make sure we get down there and see them before they discharge. So meeting with the patient prior to discharge and then discussing at that face-to-face meeting the importance of that 7 to 14-day visit in person. And then when you make that follow-up 2-day phone call, of course, reminding them again of when their appointment time is, verifying that they have transportation, and then offering to call the caregiver. A lot of our patients will verbalize, oh, yes, I have somebody, my daughter will be able to take me. But they never remember to tell their daughter of the appointment date and time. We found on a few of them. So we've been offering to call whoever that transportation is supposed to be, a friend, the family, whoever it is, and make sure that they are aware and that they are verbally saying, yes, I can get mom to the appointment on this date and time. That seems to be helping not having those no-shows on those appointment times. And then we started calling the patient even the day prior. So we're meeting with them in person. They get a 2-day follow-up phone call. And then even the day prior, because a lot of our appointments are pushing out closer to that 14-day range. So we're calling them back again and just saying we want to make sure you're still able to come and how important it is, or rescheduling. Sometimes we've had a shuffle. They say, you know what, but I'm going to have to, I could come if it was just in the afternoon. And so we've rearranged appointment times to really work around their schedules and try to make sure that they can come. Doing all of those things has lessened our no-show rate. And then also getting our providers. We work with a group of neurohospitalists they're neurologists that see the majority of our stroke patients, but also regular hospitalists can see patients also. But really getting them to understand the program, and we find that if the discharging provider is telling the patient this is a part of your normal care, that you're going to follow up with this COMPASS program for a neurology appointment, they're more apt to deem it an important follow-up appointment versus just the nurse coming up and saying, I want you to come to this appointment or this clinic. So I think having the discharging provider tell them that this is a part of their medical plan to follow up, and then we come by and reinforce that is increasing that percentage. So travel barriers are always a problem for us. We do serve 18 different counties. So like I said, discussing that plan with a caregiver, we found even while they're still in the hospital, if you ask the patient, are you willing to drive 45 minutes or an hour back to Asheville to have an appointment, they usually say no, simply because they don't want to feel like they're burdening their family. But if we've asked the family, are you willing to drive your family member back to Asheville for this important, they're more willing to say yes, that they are willing to drive them back for this appointment. So that's just one trick we've learned. And then making sure we had more options, and that's part of how we've had to now expand our appointment times to make sure, if you just have appointments, we found our appointments have just been on Thursday, all day Thursday, so sometimes Thursdays are a tricky day. So just being able to have, a Thursday and Friday or morning and afternoon appointments is helping out a little bit the more we expand that opportunity. And then letting them know that kind of a key phrase is everything we do is going to be discussed with your primary care physician, and it's going to help your primary care physician take better care of you. They seem to really like that and understand that and feel that that's important. And then another thing we realized, we use mountain mobility here. I think every county probably has, a similar program. We found out that several of those programs have time restrictions for the longer distances. So we had to make sure we spoke with the patient and then spoke with Mountain Mobility to see what time that they could come. Some of them had to make sure they were morning appointments. If we made them in the afternoon, Mountain Mobility wasn't able to schedule them. So thinking out of the box. So I don't know how many of you are with systems, but Mission Health System has smaller hospitals. Angel Hospital is also within the Compass program, and they don't have the staff really to have a backup PAC. So we discussed it and decided that now that I actually have Debbie on board, and she's our main PAC, and I'm her backup now, that I was able to then agree to be Angel's backup when their PAC goes on vacation. So, otherwise she would have had several days where nobody was really following these patients. We worked with we already shared the same Cerner system, so we worked with Compass and with a system to be able to share those patients. I can now see her same email. She utilized the same email system that we had come up with, and so I'm now able to, follow patients for her when she's on vacation. So that's helping quite a bit. Let's see what else. Whoops. That's great. The ECare Plan has been not difficult once we just got used to printing it and utilizing it. It's kind of what we've decided is after the PAC completes the post-stroke functional assessment and the NP takes the patient back to begin their evaluation, then the PAC, we've been turning around and building that ECare Plan, reviewing it, and then handing it back to the PAC. And I think Whitney kind of alluded to that too. I think every group needs to just kind of work out their flow and figure out what is going to work the best so that you can get those, appointments down to 45 minutes to 60 minutes. When we first started out, it was kind of cumbersome when we were trying to figure out who's going to do what parts, and it was taking much longer. But we've kind of gotten our flow down now where the PAC is, really taking ownership of that ECare Plan and creating it and then giving it to their nurse practitioner to review during her evaluation. So some of the successes we've had is obviously we know we're doing a good job because patients are contacting us with questions and research and concerns. Some of the things, the most common things they contact us with are rehab not started as ordered. We discovered actually that in our area, speech therapy, because of not having enough speech pathologists available in a lot of our surrounding areas, it was up to 2-week delay in initiation of speech therapy services. So we actually worked with our inpatient and outpatient speech therapy and rehab departments and have come up with some solutions to how we can better prepare the patient for discharge, making sure they have some exercises to do while they're waiting, and then the patient is aware also that, it may be a little while. Utilizing more outpatient speech therapy, they had a lower wait time than home health. Of course, the patient has to be able to get in a car and travel, but as long as making sure we weren't just kind of ordering that home health as a standing thing and really pushing out the outpatient testing when appropriate. Our stroke unit patient satisfaction surveys have actually improved, and we're, so we're pretty sure that that's, part of a testimony of us doing such lots of those touch points and contacts with our patients, so that when they get their survey of hospital care and their perception of care, they're actually saying that, we worked together as teamwork and everybody, really gave excellent care. We've had to increase our clinic slots, and we know we're catching a lot of our patients and getting them there and getting them to agree to the appointment times. And we now have 2 PACs and 2 APPs trained for those extra appointments and backup. And I think that's it. Sorry, guys, I tried to rush through a little bit to save us time. Any questions?
Hey, Melissa, this is Becky. I have a question.
Hey.
On your patient satisfaction, how is it like, is that through your vendor? Are you talking about your HCAPs?
Yeah, so HCAPs, and we have another vendor too that we utilize, and we could see a direct correlation of the time we started Compass to our certain, they'd ask the certain questions like, did you understand your follow-up care and that kind of stuff, and those scores increased as we implemented Compass.
Wow, that's interesting. So you're not extrapolating your stroke patients because that survey is random, right?
We are. That our vendor can actually poll by DRG.
Oh, okay.
We're able to actually pull it.
So yes, Sarah Day. I am a.
Oh, good. We do get a random, survey, but then we're able to filter that down by DRG.
Thank you.
Sure.
Thank you for that question, Becky, and thank you again, Melissa, for another outstanding presentation. Again, to move us along to make sure that we're able to hear our third presentation, I'm going to ask that Rika start the webinar that was created by Sarah Day from Hugh Chatham Memorial Hospital, and then we'll have a little bit of time at the end for questions on all 3 presentations. So Rika, please start the.
Okay.
This is Sarah Day. I am a registered nurse here at Hugh Chatham Memorial Hospital. I'm the post-acute coordinator with the Wave 1 team. Today I want to discuss the challenges and successes with implementation of the Compass model here at Hugh Chatham. This is just a brief introduction to our facility here. We have 81 inpatient beds, 24 emergency room beds. Usually in a year we see around 275 to 300 stroke or TIA discharges. Typically 65 to 70% of those are discharged home. And here in our area we have 1 outpatient neurology practice, and we have 1 physician at that practice and 1 PA. During the Compass launch, we faced some challenges. There's 4 listed here. Probably the biggest challenge was capturing eligible patients. During the first week, I think we actually missed 2 or 3 patients, and so we quickly learned that we needed to implement some things that people would be reminded to contact me prior to the TIA and stroke patients going home, because, this was a new intervention for us. So the first thing we did to our discharge order set was we added call post-acute coordinator prior to discharge. So when the hospital has discharged the stroke and TIA patients and they use their order set, this automatically comes up under the physician orders for the nurses to do. The next thing we did so that would take place was that we had to educate the managers on the units and the team leaders, both on the medical unit and the ICU. We also had to in the ED because we found out that we were having some TIA patients discharged directly out of the emergency department. That's unusual. We typically hold them for 24 hours for observation, but for the ones that are discharged out of the ED, we had to educate the ED coordinators and team leaders in that department to contact me prior to discharge. Also, when we had our community meeting here at the hospital, we invited a case manager to join our team, our meeting. So she's very engaged in this program and knows the importance of the Compass model. She's also here and calls me for TIA and stroke patients if there are some on the floor that she thinks I need to probably look at. I also get a core measure report every morning, so that may include, congestive heart failure patients and stuff like that too, but that's a pretty good way to capture stroke and TIA patients. I attend morning rounds. It's a multidisciplinary meeting among different specialties, physical therapy, nutrition, the physician. This is a good place for me to question the physician as to whether the discharge diagnosis is going to be TIA or stroke. It's also a good time. Our home health team is also represented there, and it's a good time for us to talk about whether the patient needs home health, physical therapy, or maybe they need outpatient treatment or something like that. There's also a pharmacist at the meeting, which is a good thing to discuss, aspirin therapy and things like that they might need at discharge. The second challenge we faced was the 2-day follow-up phone call. We didn't have a whole lot of problem with this. The main thing we found was that it's really important to meet the patient in person because that way you can verify that their number is correct. Often, the stuff listed in our system may be years old and may not have been updated when the patient came in. And so that's an important aspect of that, the 2-day follow-up call. The third challenge was the 7 to 14-day clinic visit. Like I mentioned earlier, we only have one neurology clinic in our area. The PA at that clinic, Bill Jarrett, is actually our APP. So what we did to make sure that their schedule was available was he cleared his Tuesday and Wednesday afternoon after lunch. That way I could make sure I always had space to put Compass patients. They also gave me access to their schedule so that I can just go in and directly schedule the patients and not have to bother the office staff over there. I always schedule their appointments before their discharge, put on an appointment card for them, and talk to them about it before they leave to make sure it's something that they will be able to attend, that there's no conflicts in their schedule. I also call them, especially if it's, if it's 3 or 4 days after discharge, we don't, but if it's, a couple of weeks after discharge, we call 1 to 2 days before to remind them that they have an appointment. Sometimes I do this. Sometimes some of the office staff over there does because that's just what they do. That's just part of their routine is they call patients to remind them of their appointments. The other thing, we schedule patients as soon as possible after hospitalization. So usually it will be within 4 or 5 days of discharge. This is helpful if the patient needs to reschedule because a lot of times you can still get them in within 14 days. We've had this happen a couple of times. They were scheduled 5 days out and needed to cancel, but we were still able to get them in within 2 weeks of discharge. And then again, discussing with the patient in person, the importance of follow-up is very important. Another challenge that we faced in the beginning was backup PAC and APP. For myself, we have 2 people that are my backup, the stroke and education coordinator and the director of healthcare improvement, both back me up if needed. And they did go to the Compass boot camp so that they could be familiar with the process. We do not have a backup APP, but our APP is very good to arrange the schedule for availability for me. He went on vacation actually a few weeks ago, but still managed to see all the patients that we needed to meet the 14-day mark. This is just a comparison of the enrollment process as far as weekday compared to weekend. So during the weekday, as I mentioned earlier, I receive a core measure report every morning that has the stroke and TIA patients on there. I usually look over these charts and then go to multidisciplinary rounds. That way I can discuss again with the physician, is this somebody that's possibly a TIA, whatever they need, as far as therapy and outpatient treatment and those kind of things. I then visit the patient prior to them going home, give them their folder, schedule their appointment, explain the importance of Compass, get a telephone number, and then I also tell them when to expect a call from me. So if they go home on Wednesday, I usually say, I'm going to call you Friday. It will probably be Friday morning. Are you going to be available? And that also helps for them to know when you're going to call them. The weekend's a little bit different because I'm not here. I do still receive the core measure report at home, or I receive it via email so I can see it at home, or Monday morning when I come in. And this way I can call the patient on Monday that had been discharged over the weekend and can enroll them over the phone. We also have a really good weekend case manager, and she emails me every Sunday afternoon to let me know if there's been any stroke or TIA patients discharged over the weekend. So on Mondays, when I return to the office, I review the record, I call the patient, enroll them over the phone, then I mail them their folder. I also make their follow-up appointments while we're on the phone so that they know when it is, and I send them an appointment card in the mail. These are just some tips for enrollment success. Again, the face-to-face encounter is so important because the compliance is just better. You can get the phone number, you can tell them when you're going to call, you can find out when is the best time for them to come to clinic. And I think a lot of times just putting a face to a name, it's just easier to make that connection in person rather than on the telephone. Another thing I think has been very important for us, and something that's worked really well, is involving a case manager as part of our core compass team. The case management team here is awesome. They're the ones that set up home health, PT, nutrition services, that kind of thing. And so having them come to me and let me know what patients need has been very helpful. To improve enrollment, information gathering, verify phone number, we talked about that. I also wanted to mention our NIH stroke scale. That is part of our stroke and TIA policy and admission order set criteria. I know that's a question when you're enrolling patients is what their NIH stroke scale score was, and that's been very helpful to us, is that that's a policy that you get that on admission and at discharge. Tips for 7 to 14-day clinic visits. One thing that's helped us with compliance in clinic is definitely calling the patients 24 to 48 hours prior to their appointment just to remind them to come. Also, when we do this, we find out if they can't come, or maybe they've forgotten and they need to reschedule. We can also do that at that time. Again, we try to schedule them within 7 days, so if the appointment needs to be rescheduled, we can still get it within 14 days. And then we have the dedicated clinic time that are only for Compass patients. One thing we found out in the beginning with that was, when the patients weren't showing up, then our ACP was concerned because he didn't have patients that afternoon. So we have started overscheduling a little bit and putting 1 or 2 patients. Typically we start at 1 o'clock, so we'll put 1 or 2 follow-up patients at 1 o'clock. So while I'm in with the first Compass patient, he still has a couple of patients to see. Also, while I'm in the room with them at the office visit, I go ahead and obtain the consent form, explain that to them, and get that while I'm in case they leave prior to me seeing them again. Tips for the 30 to 60-day phone call. I usually remind the patient at clinic when I'm going to call them again. So if it was 14 days out, I say, hey, I'm going to call you again in 2 weeks. And then while we're on the phone for the 30-day call, I always remind them, I'm going to call you in another month. That's when you'll hear from me again. And thank you. There's my email. Please feel free to email me with any questions that you may have. It's fhj@huchatham.org.
Okay. I'm hoping that you all can hear me now. Somebody tell me if you can hear me.
I can hear you.
Okay. Awesome. Caldwell team will always let me know whether I'm being heard or not. Thank you so much. I hope that you have found hearing from 3 of your colleagues, your teammates across the state of how this is possible. Sometimes I know that we feel like there's so many moving parts, but these were 3 outstanding presentations of the journey, where they began and where they are now and where they're headed with getting at least 70% of their patients back for the clinic visit and to receive that ECare plan. But we have 2 or 3 minutes for questions, so I just want to open up for all 3 presentations right now what questions I think we might have a couple of our PACs still on, and I'll do my best to answer any questions on behalf of Sarah, and you have all 3 of their emails so that if you have questions that we don't get answered today, you can email them. We'll make sure that you get the presentation as well as our summary, helpful hints, and tip sheet. But any burning questions right now in our last couple of minutes? Any questions at all?
I have a question.
Sure.
I know we had talked about coding the 7 to 14 day visit. Do you know if we, do you know what code everybody's using?
I can, Christina, are you still on? This might be something that we need to talk specifically about. That is not my area of expertise, and I know that there are several codes that can be used in addition to the TCM coding, extended visit coding and chronic care management codes, which is gets into some complexities. But Christina, are you still on? Can you give a general answer? I think Christina might not be on, so I'm going to make a note. Was that, Carolyn, was that you by chance?
Yes, that was me.
Okay. See, I'm learning voices from all over the state. So, Carolyn, we'll get you some follow-up on that. Are there any other questions in our last couple of minutes? Well, it's quiet out there, so I want to just remind you that we will be getting the slide sets out to you so that you can have all of the information in the slides. I took notes, so I'm going to, in addition to the tip sheet that we're going to share with you that summarizes a lot of the helpful hints and the pearls that our 3 presenters shared with you today in a one-pager, but then I'm going to collapse some additional notes and also be sharing with you over the next couple of weeks some motivational interview and coaching helpful hints that, as you feel, will be helpful. You can certainly use those prior to discharge with your patient. If you want to talk with them first prior to discharge about their 7 to 14-day visit, we want to talk with them again at the 2-day call. And when we learn about any barriers to them returning, we're going to give you some helpful information to deal with transportation issues, multiple appointments, financial barriers, travel, and so on and so forth, distance and that kind of thing. So, but because we are at the top of the hour and we have another call that's immediately following this, I'm going to go ahead and adjourn us, and thank you again to our excellent presenters for these outstanding presentations, and we will be in touch. Thanks, everyone.